Hi. First, I'd like to thank you, Felipe, and all organizers for this great course. It's a very pleasure to be here again. And it's also a great pleasure to see, even virtually, my friend from MD Anderson, Fred, Sujit, Vinay, and other colleagues. And would like to discuss one case of a low-grade glioma. Can you guys see my slides?
Yes.
Okay, good.
Sí.
So we're going to start with a teacher. She's a female, 45 years old, with no comorbidities. She had a historical of recurrent headaches, and then the neurology decided to perform an MRI. We have this lesion located in the operculum, an insular lesion, some kind of infiltrative tumor with no mismatch so far, comparing FLAIR and T2, and using there is maybe some hotspot in the posterior part of the insula. And the first question and the first issue that we would like to address is, we had the Dr. Ballester presentation giving us some radiology and pathology information. Do you guys think nowadays which MRI information is more relevant for our decision? Maybe the mismatched T2 FLAIR, the spectroscopy with the band 2HG, trying to have the information of this is a IDH mutated or not tumor, other radiomics information, or just looking for hotspots based on perfusion and choline met. Who would like to start? Maybe Fred or Vinay?
Thank you, Marcos. I can start it, and I'm sure the others would have comments as well. So, as you know, when a patient presents like this, especially in this case, in the left side of the brain, before we jump into surgical decision-making, it's good to get as much information as possible to at least get a sense of what you're going after. So of the ones that you have put in there, clearly each of them has its own value. So if you take, for example, MR spectroscopy for 2-hydroxyglutarate, the peak is very small. It is usually embedded among other peaks. So it greatly depends, I think, on the quality of the MR spectroscopy you can get and the sort of the expertise of the person reading it. So I don't know if we are yet at a stage where we can use that from a clinical perspective. Clearly for research and other perspectives and centers that have the technology, that may be a good correlative thing, but not necessarily as good. Other radiomic information in terms of advanced imaging analysis, again, is still in its infancy. I don't think we are where we can use that on a regular clinical basis. The hotspot thing is an important thing, using a number of specialties. We have, for example, in MD Anderson, something called advanced brain tumor imaging, where we use the cerebral blood volume, perfusion, MR spectroscopy, and try to do a consensus decision. And not always does it match, like the hotspot doesn't come in the same place each time. But when it does, for example, in this case, there was an enhancing area. Clearly targeting that and making sure you sample that becomes an important decision, regardless of other hotspot data. But in the case of non-enhancing tumors, I think if you do see a hotspot through MR spectroscopy or so, an attempt should be made to sample that so we get the best diagnosis. But I went through all of those to say that the mismatched T2 FLAIR seems to be perhaps the most reliable one, even though it's not 100%, to say that maybe you're getting an IDH mutant or wild type. So if you see that the IDH mutation being present is very high, if you don't see that, I don't think it's completely rules it out. So I would go with number 1 for now. And of course, based on the center, you could go with any of the others to add the information. Okay,
good. Sujit, if you have the previous information that maybe this is an oligo and you expected a better response for further treatment, do you keep your surgical planning to be as much as aggressive as possible, or considering that maybe this patient can have a relevant response to adjunct therapy, you may be not so aggressive as usual.
You're muted, Sirio.
Yeah. Thank you for that question. I think it's a very, very important question, and I wish we had, a lot of some good data to support it in terms of, maximizing resection in a safe manner, especially in biopsy proven or maybe even based on MRI imaging with oligos. I would say, I do prefer not to be overly aggressive, so especially with if I know it's an oligodendral glioma grade 2. Clearly, we know there are therapies which help, but I'm still very open to maximal safe resection, even in the insular tumors. Clearly, there are aspects of the tumors, and you showed that example. Obviously, it's it's basically like a paralimbic insular tumor in terms of its location, right? It's not purely an insular tumor. It involves probably the perforating vessels. So really, there are parts of the tumor you want to be careful with, where I would be really hesitant to resect. So the bottom line is, I will say I still prefer resection of these tumors, but with the caveat that you want to reserve the adjuvant treatments to work for the residual disease.
Okay, thank you. And considering the hotspot, because we are probably dealing with a low-grade glioma, but we have this advanced MRI technology, mainly on the oncology point of view. We can discuss perfusion, spectroscopy, and ADC map, but do you have one specific that truly make you go further the resection, or at least biopsy this hotspot? And maybe Fred can answer this one. Do you believe which one is the best one for perfusion, choline map, or ADC map?
So I think the contrast enhancement on the MRI is a good indicator that there's potential vascular change there, microvascular proliferation. So I would like either surgically, I would like to surgically biopsy that. So if I'm taking that out, I will try to find that and sample that separately. All of these other things are valuable, but I don't think they're all probabilistic. And the best is direct pathological diagnosis of that hotspot. I don't think that's going to necessarily change the tumor type, but it might change the grade, right? So if this is an IDH mutant tumor, it could make it a grade 4 if you actually find microvascular proliferation there. So I think that finding that is important, but of these tests, I don't know if any one is better or worse at making a definitive diagnosis.
Okay, good. Let's improve the question. We are used to have this in the practical point of view. We have this standard MRI with the traditional sequences of T2, flare, diffusion, and contrast enhancing one. But when you have a diagnosis of a low-grade glioma, should we perform this advanced MRI techniques, considering extra costs, considering another MRI that the patient should perform? And do you think it's enough to deal this patient without this kind of information and go further for the surgery?
Yeah. From my perspective, none of this is necessary. From the surgical point of view, the decision to surgery is, do you think it's a tumor? Where is it located? And what's the important functional areas around it? And is it enhancing or non-enhancing? So it's not necessarily what it is that matters to the surgeon, but where it is. And then all of the rest of the treatment depends upon the histological diagnosis from the specimen. So once you have the histological diagnosis from the specimen, all your previous testing is basically moot. So to me, that's the most important thing, getting a good biopsy of and sampling the entire tumor.
Okay, good, thank you.
Doctor Maldaun,
Yes,
doctor Maldaun.
yes, Felipe, I'm hearing
Me
you.
gustaría hacer una pregunta ahí,
Yes.
un poco complementando lo que se está hablando. Es una pregunta directamente a Marco. ¿Ustedes usan en estos casos pre-quirúrgicos, pre-decisión quirúrgica, digamos, y hasta qué punto, cómo interpretan la resonancia funcional del lenguaje, por ejemplo, y motora? Y también la misma pregunta al doctor Lang.
Okay, in my point of view, I had the opportunity to participate for a great paper published with Sujit that compared functional MRI with interpretive mapping, and we have a discrepancy, a significant discrepancy for language so far. And we know that the tasks that we use to perform it for language testing during functional MRI are pretty much not enough to cover the whole language set for all patients during traditional awake craniotomies. And so no, I'm not used with a functional MRI, only when we have some kind of issue regarding sides. So this is a right-sided lesion, maybe he has some kind of a dominance in the right side, and then we used to have this kind of testing for language functional MRI. DTI is definitely useful, is another tool. I believe that it's not crucial. I do believe in patient clinic. And then this is another question for Vinay that we should then probably doctor know as well. But DTI can help us to prepare our patient for good accessibility and resecability for our lesions. I wonder if Fred agree with me, or he's a big fan of functional MRI.
I think that the functional MRI is valuable to give you some idea about where things are. It certainly distinguishes left brain from right brain for speech. It's pretty good for motor, but even there, you can stimulate and sometimes take tumors out of the motor cortex. Again, we're talking about non-enhancing tumors. Enhancing tumors can be taken out of the motor cortex. The correlation between actual mapping and what you find, intraoperative mapping and what you find in the functional MRI is not 100%, particularly for language. So, and I think Sujit can comment on that as well. So I use it as a general guide. But for example, if I see a positive site inside the tumor, that does not detract me from going in and doing the operation and seeing if that's a true site. Because a lot of this, again, is the radiologist can change the leveling, and you can get areas that you may or may not see depending upon how you do the testing. So I think it's a general guide, but not an absolute. Sujit, would you agree?
Yes, 100%. I think I use it more as a, roadmap, as it were, to help me understand, function as it relates to the tumor. Really, for me, it's more in terms of, it's intraoperatively to kind of help me understand the orientation of the various fiber tracts, as well as the activity or the functional MRI activity. Yep.
Could I add a point to that, Marcos? The other aspect of it, I'm sure Fred and Sujit will agree, is the plasticity of the brain in terms of slow-growing tumors, that these traditionally localized areas might have drifted and relocalized or changed in position. So there are variables that may enter into the picture in those situations as well. I just want to make that point, but I do have a question, if I could, to Fred and Sujit and Marcos. If this is a non-resectable tumor and you're forced to do a biopsy, would you then depend on some of those features, MR spectroscopy, diffusion perfusion in terms of deciding where in a non-enhancing tumor you would perform a biopsy.
I would say, yeah, that is the place where some of those tests would help you. You can find areas of hyperperfusion, or, again, if there's an area of contrast enhancement, I think you want to biopsy that. So in those cases, if you're going to do a biopsy, yes, that's where those tests are helpful.
Okay. So let's keep moving with the case. Considering a low-grade glioma patient, and we know that seizure is the main symptom that used to appear for this kind of patients. Do you think we should provide or give a prophylactic antiepileptic drug for a low-grade glioma patient? Vinay?
So it's a great question, and I would say a qualified no. And the qualification would be that we understand that seizures happen more often in low-grade tumor patients than in high-grade tumor patients. Initially, we thought it was the slow growth of the tumor, the infiltrative nature, the irritation of the brain. But we now understand that there may be other factors, such as 2-hydroxyglutarate secretion from IDH mutant tumors is an irritant to the brain, and it can trigger excitotoxicity of the brain, causing seizures. So there is a question of whether such prophylaxis should be done. But anticonvulsants are not without issues. They have their own side effects. And if you're committing a patient for very long-term treatment, because once you start prophylaxis, you don't necessarily know when to stop, I think it should be considered very carefully. And younger patients, especially who get lower grade tumors, are functional. And I have seen many cases, even in symptomatic patients, where things like levetiracetam or lacosamide can cause mood changes and other fluctuations that impact their function quite a bit. And if you go on to the enzyme-inducing anticonvulsants, they have their own level of side effects as well as interaction with other drugs. So unless they have seizures, I do not usually put them on prophylactic anticonvulsants. We do wait to see if there is anything but we have to be very vigilant about the nature of seizures, because it's not always a convulsion. And it's important to educate the patient to recognize what a seizure can be in complex partial seizures, simple partial seizures. The patients identify when that happens, and that way we can decide on starting anticonvulsants. I'd be interested in hearing Dr. Sinning's opinion as well.
Yeah. Mariana?
Yo iba a decir lo mismo, que uno lo que tiene que hacer es una buena anamnesis con orientación de búsqueda de síntomas focales. Pero si no hay ninguna evidencia de crisis y eventualmente el paciente recibe en el perioperatorio, uno retira los medicamentos y yo comienzo a retirarlos a la semana. Pero hay que buscar las crisis porque los fenómenos no siempre son evidentes.
And extending this issue for Sujit, you are very used to do surgery in eloquent brain areas, and you are going to test your patient. And do you feel comfortable to test your patient awake or sleeping without prophylactic antiepileptic drug? I mean, do you feel safe to perform it?
So this is if I could jump in, this is a great question. We actually tried to do a prospective clinical trial. We actually had to stop the trial. We were assuming that the rate of seizures was a certain number, which turned out to be very much higher than the actual rate of seizures inside our study. The rate of seizure, so this is about patients who are undergoing surgery, craniotomy, not the standard patient. So if the patient's not undergoing surgery, I agree with Dr. Pudavali. If they don't have a seizure, there's really no need to put them on prophylaxis. If you're taking them to the OR, that might be a little bit of a different situation because now you're manipulating the brain. So having said that, the rate of seizures was quite low. It was less than 1%. The trouble is when you have a seizure, it is actually a quite devastating thing perioperatively to have a seizure. So, and the group of people who had the highest seizures were actually those that we were doing intraoperative stimulation. So my practice is to, if I'm going to do intraoperative stimulation, to put them on anticonvulsants to try to reduce the potential for a seizure intraoperatively, but take them off by 7 days or 2 weeks after the surgery so that they're not on long-term anticonvulsants. I would be glad to hear what Dr. Prabhu does also.
Yeah, I agree. I think for me, it is what happens intraoperatively, and as we all do, we look for after discharges, and I think there is a frequency of after discharges where you can have very constant after discharges at remote parts of the grid wherever it's placed to pick up these seizure activity. And my threshold, especially intraoperatively, is pretty high. If I get information saying we are getting after discharges with every second or third stimulation, clearly we are getting good information regarding the mapping process, but intraoperative after discharges clearly is important. But I have the same algorithm in terms of treating them intraoperatively. I usually like to use dilantin intraoperatively or phosphenitoin, and then stop it at a week. But one thing I will comment here, because what the big unknown is, do these patients eventually develop seizures? I'm not sure about the data. Say a patient who comes in without seizures, he has a surgery, but then goes on to develop seizures, right? And I think some of the studies which I'm hoping we will be doing here, trying to look at seizure onset zones using the grids we are trying to use, will hopefully throw some light on this question, because I think there is, like Vinay mentioned, there is clearly epileptogenic tendency for the peritumoral brain or the tumor itself, and I think that's a little unknown. But Vinay, do you know what the incidence is of patients who eventually develop a seizure in low grades, though they initially present seizure-free?
I think it's a quite a high level.
I was on mute. Yeah, it is quite high through the course of the disease. It can be, I think, variable from 40 to 60% of patients, one way or the other. But the onset of the seizure can be varied. Most of them present with seizures, so that's actually makes that decision easier. But it's the patients that come through the rest of the course of the disease that's a little more difficult to track and see when exactly that happens. So if a patient presents with other neurologic symptoms that are clearly not seizures, then that's the situation that I was referring to, where you may want to wait and see what that tumor. Because when you remove the tumor and the some of the irritant is gone, then the degree of 2-HG production is reduced. So even if you look at it pharmacologically, there is a benefit from removing the tumor in terms of that irritation. So to see how that actually plays out might make sense. From a peri-operative perspective, obviously it makes great sense to be as careful as possible. And I was talking about other than peri-operative situations where if the patient has not had seizures, we generally don't do that until we see. But the frequency is high, but you can avoid the burden of that until something like that happens.
And particular this case, the patient present one seizure. And Mariana, what is your pick? Which one is your drug of choice, anti-epileptic drug, the best one for low-grade glioma in your point of view?
En general, nosotros partimos con levetiracetam inicialmente, salvo que haya algún elemento que nos haga no utilizarlo, y eso habitualmente tiene que ver con patología psiquiátrica o pacientes con antecedentes de haber tenido ya problemas. ¿Por qué nos gusta el levetiracetam? Porque es de inicio rápido, es decir, uno puede partir, si bien el paciente se seda, uno puede partir con dosis altas, no como la motrigina, que es un fármaco que muchas veces lo usamos más adelante, pero que para el debut es de muy lento inicio, y también porque tiene la alternativa endovenosa. ¿Ya? Ácido valproico, actualmente no tenemos alternativa endovenosa en Chile, un problema puntual. Los neurocirujanos no les gusta el ácido valproico, sí. Y la lacosamida, por un tema de costo, la dejamos también para una segunda elección y para ciertos pacientes seleccionados. No sé qué piensa el doctor Puduwal.
I'd like to extend the question like a myth or reality, because we've been discussing for many years that maybe valproate and deacetylase process of this drug is related with a better outcome for glioma patients. And I extend this question for Dr. Zaki as well. In the pediatric population, do you guys believe that this is a myth or a reality, the use of valproate drug related with better outcomes for glioma patients?
Dr. Zaki had to jump off, I think.
Oh, okay, so Vinay, what do you think?
Yeah, so the whole idea of valproate as improving survival is because of also its potential anti-tumor effect. And the anti-tumor effect is supposed to come from his histone deacetylase inhibition potential as a mechanism of reducing tumor growth and inducing tumor kill. The only challenge is that the typical doses we use for anti-seizure prophylaxis or seizure treatment is not enough to inhibit histone deacetylase. You need much higher doses. And so if you go into those doses, the toxicity of the drug is also quite a bit. So at the doses we use for typical anticonvulsant treatments, I have not seen evidence enough to say that that is beneficial. So we don't use it for that purpose. Valproate also in women has weight gain and other signs like hirsutism and other things coming up. So it's not a good drug to use for women as well, generally, especially young women. And in men, there can be, again, interactions with other drugs, hepatic processing. So given that we don't know that it has any benefit in glioma patients in survival that we can confidently say, given that it does not inhibit HDAC at that dose that we use for seizures, and given that it has side effects, I generally don't prescribe this as first line unless we have some real reason to do so.
And Fred, there is another myth that valproate, when you operated a patient under a valproate therapy, you might have some coagulation problem. Do you think this is a myth or maybe it's a reality?
I can't comment on that. I don't operate on too many patients on valproic acid. My understanding is it can be a platelet inhibitor. So I tend not to like to have the patient on valproic acid Depakote when I'm operating. But if that's the best anticonvulsant for them, we will move ahead with the surgery.
Now, Marcos, I think I have one, I've had one patient where we did have significant, issues with bleeding, clearly under control, but I think it's real. I think if they're on long-term valproate acid, they haven't, cannot be changed to anything else. It can really be an issue. I think it has to do with the time to, as long as they've had it for many years and so on. So, but it can be an issue.
Okay, good. Thank you, Sujit. And do you think it's essential to operate this patient, particularly this patient awake? This is a frontal insular tumor.
So I'll comment on that. I like to do my insular tumors trans-sylvian. So, and I've stimulated the insula itself on multiple occasions and have never found speech in the insula itself. Having said that, I do most of these operations, I do all these operations awake, but the first half of the operation is done with the patient sleeping. And then as I get more posteriorly and deeper, I tend to wake them up. And that gives me confidence that most of the time that I haven't hurt something, and allows me to then proceed on to be more aggressive with the deeper parts of the tumor, particularly the arcuate fasciculus coming around the back and the cortical spinal tracts coming around over the top of the tumor. So I like to do it awake. I think it gives you extra confidence that everything is okay as you're proceeding.
And do you awake your patient after the fissure dissection or before the fissure resection?
Now, I dissect the fissure, expose the majority of the tumor, and then most of the time simply monitor the patient as I'm working and then do deep cortical stimulation as I'm getting posteriorly.
Great.
Yeah.
Good. Thank you, Fred. And I wonder if Dr. No is with Kyle, is with us so far, but do you think it's crucial to have a pre-op neuropsychological testing for patients with tumor in eloquent areas for all of them, or only under demand, on demand?
Honestly, I'm biased, but I would say it's helpful to have pre-ops on everybody. Say a patient develops a deficit and you want to know how severe that deficit is post-operatively, you really have no frame of reference without the preoperative evaluation. I'll also say regarding this patient, Dr. Lang has published a series of cognitive outcomes regarding resection of insular tumors with some of our colleagues here in neuropsychology. And like he was mentioning that, he's not encountering much speech deficit, and it's definitely what we see in terms of our cognitive outcomes as well. Speech is relatively preserved. Interestingly, what you do see are the deficits very consistent in terms of prevalence to patients with temporal lobe tumors in terms of deficits in memory and executive functioning. So those really are the areas that we have most risk of cognitive declines. We do a pretty good job of preserving language functioning. But we also, one of the issues is we don't really have ways of mapping some of these other higher level cognitive abilities, which I think is one of the reasons why they're more at risk than language per se.
Okay, good, thank you. And Vinay, we are neurosurgeons, and you know that we are trained with the Glasgow coma scale, that it's a conscious scale, and you guys oncologists were trained with the KPS scale, and recently, like 4 or 5 years ago, we have this NANO, the neurological assessment in neuro-oncology, trying to assess clinically these patients in a different way. Do you think that NANO should be considered the gold standard clinical assessment for all neuro-oncological patients or glioma patients?
I think NANO is a great effort to try to standardize neurologic assessments, because previously we were using instruments that do not have as much relevance to the global neurologic function of patients. And that's the reason why NANO was attempted, because the KPS is good for functional things, but sometimes patients can look like poor KPS and still have long survivals. And maybe the numbers may not reflect exactly what the patient's status is. Similarly, mini-mental status and other types of things are fairly gross instruments, so they don't pick up fine points. And that's the whole idea of creating the NANO scale. However, NANO is not a validated scale yet, in the sense that it's not been prospectively validated in terms of assessments. And those things are going on right now with the idea of trying to put them in clinical trials and look to see if they can be validated in real life in terms of outcomes. So I would say it's a great effort, and it probably captures more of the neurologic aspects of the disease than many of the scales we currently use. It's probably not a substitute for other things, but it has certainly a bigger breadth. I would say good to include in clinical trials, good to incorporate in your templates of notes, but not rely on it solely to make a decision. I don't think it's yet the gold standard.
Mariana, do you apply NANO, or you're keeping using Glasgow and KPS? Or...
No lo aplicamos en forma... Ocupamos KPS y evaluación clínica. No ocupamos NANA como una escala métrica. Hacemos MOCA habitualmente a todos los pacientes también, como un test de screening.
Okay, thank you. Returning to the surgical point of view, do you guys think it's crucial to have motor intraoperative monitoring? I mean, agreed on and testing motor all the time. We know that, and Fred can answer that because you are a specialist in insular tumor. Do you think, and mostly the tragedies are vascular based, how motor intraoperative monitoring useful in a case like this?
Yeah, so if you're talking about continuous motor evoked potentials, I don't do that. I actually dislike it because I think it's overstimulating the cortex. And so I just simply monitor the patient, with movement. But I agree, I'm not so sure. It helps you when you get to the back superior part of the tumor in insular tumors because the corticospinal tract is often draped over there. But most of the time, the problem is the blood vessels. And really, it's learning to dissect the blood vessels and making sure you preserve the lenticular striate perforators that is critical to the operation. Again, the patient is awake mostly to give you confidence that things are okay, rather than to, necessarily detect something earlier.
Good, thank you. And Sujit, this is a low-grade glioma. Do you think is there any rule to use intraoperative ultrasound as a useful tool for a low-grade glioma?
I believe it is. Ultrasound is definitely the workhorse, during surgery. As you know, we have used that for many years, and for me, it is crucial. I would say as a intraoperative technology, it helps me, look at the, clearly the margins, especially around corners, right? And the insular tumors are notorious for that, where you can have tumor under a lip of either the operculum, frontal or temporal, especially deep in the temporal lobe. So I think I would say absolutely.
Okay, good. And how about intraoperative MRI? We know this is a good tool, but do you think it's the best way to achieve a maximal resection for a low-grade glioma?
Sujit, you have a lot of experience with that. Why don't you take it?
Yeah, you can see I'm a little tentative because it is an excellent tool, for obvious reasons, and for low-grade glioma, more so. I would say, it's a tool. If you have it, using it really makes sense. Clearly, you can operate on low-grade gliomas outside the intraoperative MR and probably get as good results. And we have data to support that, right? Not necessarily from here, but we, even with our surgeon mix, you can tell. But I think the role of intraoperative MR again is in more challenging locations, right? Insular being one of them, but again, it's these corners and which really defy you sometimes at surgery, and so I would say yes, just for that reason, and I'd like to hear what the other surgeons feel.
I have the bias too, because we used to have IMRI so far. But extending this question, maybe for Fred, around the world, we have some groups or several groups that are big 5-ALA fans. And we have some publications for low-grade glioma as well. For high-grade glioma, I think it's a pretty solid way to improve your resection. But do you guys believe 5-ALA can so far or any kind replace the IMRI to maximize resection?
So we're having increasing experience with 5-ALA. I think for glioblastoma, it's a nice adjuvant. It lights up quite nicely and you can see the enhancing portion of the tumor. For low-grade gliomas, they do not usually show up on 5-ALA. And so I tend to, I don't think it's a useful adjunct for non-enhancing low-grade gliomas. I know people are working on technologies to try to detect it, but in general, it's not really of a clinical advantage. So identifying a dye such as 5-ALA, that will light up a low-grade glioma would be a major advance in neurosurgery. And I think that should be an important area of research.
Okay, good, thank you. So we performed this case awake, and this is after the probably we expected a gross total resection, transopercular resection of this lesion. We have the next door MRI, so the patient is transferred to the next room and perform the MRI. This is a good coffee break for surgeons during the exam, and we have our coffee and donuts and so on. And then when we just came back to check it out, the extent of resection, this is the surgeon, not nightmare, but an upset situation, because we just check some residual tumor in the posterior part of the insula. And maybe really near to the enhanced portion of this possible hotspot of this frontal insular tumor. And then what is supposed to do? Finish the surgery because we have a negative mapping, or continue resection based on this residual disease? What do you think?
I would say you should complete the surgery, right? I don't think you should leave that residual tumor. You know, I would say, you know, that's the area where posterior and superiorly is where I have the more challenges with residual disease, and Fred alluded to that too. And it's interesting that your ultrasound always tells you that there might be disease there, but it's just the challenge sometimes getting to that area, and then you have an intraoperative MR which will just tell you that there is some residual disease. So you're between a rock and a hard place, you know, intraoperatively. But nevertheless, I would continue with the resection.
Fred, do you agree?
I agree. You did the intraoperative MRI with the goal of taking out all the non-enhancing tumor. You're now seeing non-enhancing tumor on your intraoperative MRI. You're obligated to take it out. If you aren't going to do that, if you aren't going to take it out, you might as well not do the intraoperative MRI. Right. So the purpose of the intraoperative MRI is to identify residual and then to proceed to remove it.
We know that this is a surgeon decision, and we decided to continue with surgery and resect the residual disease. But we know that the posterior part of the insula is maybe the critical portion regarding speech and mainly motor deficits that could appear. So Dr. Null, do you think that we should include this quality of life and daily activities scales pre and post-operative to our glioma patients, and maybe help the surgeon to have a proper decision to be more aggressive or not, based on the daily activities and the function or professional or job or hobbies of our patients that can limit or extent of our resection?
I would say those are definitely important considerations. You know, I assist with some intraoperative mapping, and I know, at least when I work with Dr. Prabhu, you know, a lot of it is really tailored to discussions with the patient preoperatively on, you know, what the risk of deficits would be for them, what that would mean for them in terms of their life, their quality of life, and, you know, how much would they be willing to tolerate a difficulty, say, in speech or memory deficits. Obviously, you know, weighing that with, you know, the need to get as maximally safe resection as possible. But I think the only way that we're going to really understand the potential risks is to measure them. And I think we need the data to determine who is at most risk of these deficits, to give them the best information possible. So what I'd like to see is something like a risk calculator, where we can put in lesion size, lesion location, proximity to important white matter tracts, proximity to eloquence as delineated on fMRI and TMS, and then give them some sort of within bounds of confidence interval, some sort of understanding of the risk that a a resection in this area might convey to them. I'd also like to point out something about mapping that we didn't really touch on before that Dr. Prabhu might want to also mention. You know, we talked about TMS and fMRI. We did a meta-analysis looking at the modalities, and as Dr. Lang aptly pointed out, you know, the specificity of the fMRI findings is poor. Oftentimes doesn't correspond to intraoperative mapping. However, if you combine the fMRI with the TMS and you have corresponding hits within bold activation, the specificity and sensitivity increases quite a bit. And then Dr. Prabhu is spearheading some work looking at the very importance of negative mapping on TMS, where not having hits on TMS may actually convey better outcome and or more safe resection. And also cognitive abilities, cognitive testing to kind of push this forward as well can help you inform these mapping methods, where we did a paper looking at what is the impact of patients preoperatively that have a language problem. They have problems with their verbal fluency. And it turns out they have a whole lot more false positive hits on their TMS mapping. So we're getting a lot of hits, but it's not exactly reliable, and it may be due to the fact that they're already having some deficits preoperatively. So I think there's a role to kind of combine all of these in terms of surgical planning, and then we need to really understand, were they helpful in terms of the patient's outcome? So yeah, I would say it's important to measure them. I don't necessarily think comprehensive neuropsychological evaluation is the end-all be-all. There are different ways to do screenings, but I think we should definitely pay attention to those.
Thank you. So we decided to continue resections.
Marco?
Yes?
Marco, necesitamos en 2 minutos más, más o menos terminar. Perdona.
I'm sorry, because,
It's okay.
Let's keep moving for important issues. So we complete the resection, and this is a low-grade astrocytoma, IDH mutated one. I'm gonna skip this. And do you guys believe that this IDH, ATRX, and histona immunohistochemistry is enough and should be done for all low-grade gliomas? Vinay or Dr. Ballester? I wonder if he's still with us.
So I don't know if Leo is still on.
I'm here.
Okay.
IDH,
Thank you,
TRX,
Ballester.
H3, testimony.
Same.
So the H3, the IDH and the ATRX, yes. The H3 K27, we typically do it based on location. If they're midline gliomas, then we will do it. Not so much for hemispheric gliomas. So.
And so do you suggest it to perform like a FISH, 1P90Q, or NGS for these patients, or this is enough to roll for diagnosis and prognosis?
So ATRX loss and 1P19Q codeletion are mutually exclusive. There are some rare exceptions, but they can be considered mutually exclusive. So usually we do the immunohistochemical stain, the IDH, the ATRX, and the P53. And if the tumor is IDH wild type, then we don't worry about 1P19Q codeletion, because it has to be IDH mutant in order to be an oligodendroglioma. If it's an IDH mutant tumor and it has ATRX loss, then we know that's an astrocytoma and it will not be 1P19Q codeleted, because if there's an ATRX mutation, you will not see the 1P19Q codeletion. So in the setting, only when we have an IDH mutant tumor, ATRX is intact, then we consider oligodendroglioma, and in that setting, we do the FISH for 1P19Q codeletion. So it's actually a very small subset of cases where we send for 1P19Q evaluation.
Okay, good, thank you. And Vinay, is there any rule for Mgmt mutilation for low-grade gliomas?
Well, I think the information there is still evolving. In some of the more recent low-grade glioma studies that have been done, there seems to be a tendency for Mgmt methylated patients to do better. but it's not as clear as the glioblastoma patient. So I think we need to wait a little bit more about understanding what that means, especially with the IDH mutant tumors and the methylation profile. There's the GSIMP-like profile that includes MGMT methylation in there. So I would say not yet from a therapeutic perspective, but certainly it's being done just to accumulate that information. But I'd be interested in seeing what Leo has to say as well from a pathology perspective.
And do you think we should perform an NGS for all patients, glioma patients?
We go ahead.
Go ahead, Dr. Pudivali.
No, please, Leo. You see this more often, please.
I was gonna say not for all gliomas. For example, the 65-year-old patient with a contrast-enhancing lesion and histologic features of glioblastoma, the IDH immunohistochemical stain is enough, right? You know, in imaging, it looks like a glioblastoma. The age is consistent with glioblastoma, and the histology is consistent with glioblastoma. All you need in reality is the IDH1 R132H immunohistochemical stain. You really don't need to sequence that tumor.
And
now,
in the therapeutic point of view, Vinay, do you think it's can provide you good information for maybe a personal therapy treatment?
I think it is identifying these occasional cases that may have targetable mutations that might come in handy. Even that in the upfront setting, we rarely use targeted therapies as a sole mechanism. So for example, BRAF V600E or other types of tumors coming up, things like FGFR fusion, FGFR3 fusions, etc., are uncommon in low-grade gliomas. So I think the yield of that is probably not very high in these patients, but for reasons related to what Leo was just saying, in select cases when some of these things are not clear, then to identify the patient, the tumor better, there may be a value for doing NGS.
Okay,
and the same goes to also methylation profiling, because there are unusual tumors that don't fit any category, and then trying to get a better sense, methylation profiling might also be useful.
And Mariana, this is an IDH mutated patient with a complete resection, but she's 45. Do you think she's a high-risk patient or a lower-risk patient to receive treatment?
Sí. Según los últimos criterios, la edad ha ido perdiendo importancia cuando tenemos el estudio molecular. Este es un caso en donde sí uno quisiera conocer la mutación del CDKN2AB, que ya vimos que en los astrocitomas mutados IDH mutado podrían seleccionar un grupo de mayor riesgo, ¿ya? Yo personalmente a este paciente, aunque tenga 45 años, si la resección es amplia, lo observaría, pero yo sé que esa es una conducta que es gris, que hay muchos centros en los cuales lo tratarían principalmente porque el estudio de radioterapia secuencial con PCB randomizó a estos pacientes a ese tratamiento.
Okay, good, thank you. And Vinay, I'm just about to finish. And I'm running to make some important questions so far. But Vinay, do you think we decided to treat this patient? Do you think temozolomide is superior for PCV? Following this rationale from Mariana, do you think a PCV should be performed instead of temozolomide, or whatever?
So I think some of this depends on whether you're a purist or you are willing to accept data from other angles to try to apply to your individual patient. And it's a very specific sort of decision making. So in the setting of a low-grade glioma, particularly astrocytic tumors, at this point, if it is anaplastic in this case, if it is an anaplastic astrocytoma, the data is pretty clear from Catnon that if you use radiation and temozolomide, that would be an appropriate treatment. Otherwise, in lower grade tumors, like Dr. Sinning was saying, 45, that's the time of detection of this tumor. If that tumor had been in a more eloquent area, that may have been detected when the patient is 40 or 35. And then if the gross total resection is done, do you treat or not treat? So I know purists that would say if it's below 40, you observe. Above 40, the risk of transmission is higher, that you treat. And in my practice, I have been offering radiation followed by PCV for low-grade patients who are in the high-risk category. If it is an oligodendroglioma or deleted, that is the best evidence that we have so far. We are waiting for the Cordell study to tell us if those are equivalent, because it's not always equivalent. So I mean, they are not the same alkylating agent. Temozolomide type of alkylation is a monofunctional alkylation. The CCNU is a bifunctional alkylator with cross-linking. So there are differences in the drug. So we don't know for sure we can just switch from one to the other because of toxicity, preventing toxicity using Temodar. So I would be, at this point, I'm still using radiation followed by PCV in patients who are low grade with residual disease in the setting.
So unfortunately, I had some good questions for you guys, but we are out of time. And I have only the final question, $1 million question. But before that, I'd like also to thank my fellow Dr. Villani that helped me to prepare these slides. And if you guys have a $1 million award to spend in research for low-grade glioma and the low-grade glioma field, what is your choice? To have some immune lab with vaccines, an oncovirus, a CAR T cell, anti-PD-1 or another immune checkpoint, protons or some radiotherapy research, personal therapy based on NGS, radiomics, keep improving molecular and genetic diagnosis, maybe some new tool that improve surgical resection or other. For all speakers, maybe starting with Dr. Ballester, which one is your pick to start your $1 million award lab?
It's a very difficult question, considering that options 1 through 8 have been tested to some extent, or many of them with very limited success in gliomas. So I don't know, because I don't know. I would choose other, but I cannot specify what that other will be at this point. Improving surgical resection certainly could have an impact especially in low-grade gliomas. That would be one option, and improving molecular genetic diagnosis. I'm biased because that's what I do in my practice on a daily basis, and we have come very far. And I think that made a significant difference, right? If you're doing clinical trials and your cohort consists of several diseases mixed together, it's very difficult to evaluate successfully whether or not a therapy is working. So I think that ability to separate patients into homogeneous groups based on molecular alterations is critical for any clinical trial. But we've come very far with sequencing, so I don't know that I would spend my $1 million on that any longer.
Vinay?
I really don't have a good answer, but I'm sure Dr. Pudwali has some good ideas about how to invest this in terms of therapy.
$1 million these days is not much money for research, actually. But having said that, I would say
with our inflection in South America is nothing so far.
So the key thing to me is low-grade gliomas, the large majority of them are IDH mutant. So I think there is a flag in practically every cell in the tumor that we should be looking at exploiting. So the IDH vaccine trial that Mike Platten and his group just reported, mid last year, looked at the vaccination for IDH mutation. I think it's an interesting immune approach, and it's just a phase 1 trial. There is more studies going on. Be interesting to see how that works. The part to me, I'm thinking, is how do you exploit the IDH mutant alteration in the metabolism within the tumor cell, which is not present in the normal cell, but may be present in practically every tumor. So if I had $1 million to invest in it, I'd be looking to see how can I use that altered metabolism within every single IDH mutant cell that I can turn off that cell, and that would not hit the normal cell. So this is where I would put my money in. I don't see that here yet. Probably fits in the other category.
And Vinay, considering that you mentioned IDH, do you think the next conference we should change the low-grade glioma and high-grade glioma section for IDH mutated or IDH wild-type section? Or
Absolutely, absolutely. I think the field has now evolved where some of our terminology has to follow the more current ways of looking at these tumors, and then hopefully the treatments will follow in the same direction.
Thank you. Sujit, your pick. For your lab.
Sujit tuvo que irse, Marco.
Okay. And,
No está en este momento.
Fred?
Tuvo que partir por trabajo.
Okay. Fred, your pick?
I think Fred too.
As well?
Yeah.
Fred also had to leave, Marcos.
Yeah.
Okay. Mariana?
Sí, terapia personalizada probablemente porque uno quiere opciones de tratamiento para los pacientes, ¿ah? Pero probablemente estudio molecular también es muy importante porque aún no sabemos todo de estos pacientes. Todavía hay muchos pacientes que no son categorizables con los estándares que tenemos.
And Felipe, your choice?
Desgraciadamente no existe la opción todas las anteriores, pero no alcanzaría el millón.
There's enough money for all of them.
Yeah, no money for, no, but yo tengo un conflicto de interés. Yo iría por tools to improve surgical resection.
Good. So thank you very much for all
Muchas
the
gracias.
and the speakers. And again, I'd like to congratulate Felipe and all the organizers and Hospital Alemanha staff that provide us such a great meeting again. Thank you.